pleasure to be here and good to see those that I know, hopefully meet more. I'm Emily Smith. I'm originally from New Mexico and Texas, so if I have an accent, it's a mix of that and North Carolina. For 4 years, acquiring a little bit of that drawl. So the title, like Dr. Hagelin said, is the application of epidemiological concepts to global problems, and how do you provide a framework for going from epi to policy, epidemiology. So just as an overview, I'll give a global definition of global health as some challenges inherent either in global health research now or will likely be in the future. And then provide a framework of what I did, the epidemiology to policy framework, meaning how do you go from research, specifically as an epidemiologist, to policy, and then give you a real world example of how that's played out in my own work and a brief conclusion. So to start out with global health, this is the Lancet paper from 2009 that Dr. Merson has been a part of, is an area for study, research, and practice that places a priority both on improving health and achieving equity in health for all people worldwide. So at its core, global health is broad, right? It has levels both at the population and the individual level. It's multidisciplinary, it's preventative, it's curative, it's very large. Now, when I use the word global health for the rest of the talk, I mean research conducted in low to middle income countries, with the caveat that global health also encompasses high income countries, but that's what I mean. So some challenges inherent in global health research is that context matters. So it matters where we do our research. Some problems in one context in a global health setting might not strictly be applicable to other settings, or the factors that affect the logistical issues, transportation. You guys that have worked in global settings, you know that you can move from one place to the next, and the factors affecting those two communities can be very different. We have to keep that in mind, and that's at the core of people, right? I would also argue that there are specific issues affecting research that I think are different in a global health setting versus high-income countries, and the first is attrition. So as an example, this is the stage in the HIV/AIDS treatment cascade. And what it does is it tells the story of when a person, an HIV-positive person, is diagnosed all the way to their link to care, they continue to be in care, they get on treatment, they're retained on treatment, and then the overall health outcome is virological suppression. That is our goal of where we are going to. However, there's attrition, right? There's lots to follow up along this entire cascade, where if you start with 100 people who are HIV positive, you end up in the US with 28 that are virologically suppressed, meaning that cohort at the end of your health, of that health outcome, is a different subset probably than the initial cohort that you started with. And what that means is that's like a randomized clinical trial. It's a bubble of a person, of a cohort, right? So what we find among these people is probably not generalizable to the rest of the cascade, particularly those that we started with. So attrition affects studies in the US. Those blue bars are the US, the green bars are Africa. The attrition cascade, the attrition drop is even more dramatic. And then I would also argue that issues affecting research are different in times of financial constraints, and that's not only in regard to individuals not having as much money or resources allocated, it's also countries that are limited in terms of resource allocation. And that's involved in the strength of the health system. Now here in the US, we're big right now on what we call a medical home. You heard that term? Continuity of care, electronic medical record transfer, right? So it's having one story regardless of where you get your care. Now go to a global setting and think of this issue of a medical home or continuity of care. Is probably non-existent in many places, especially the lower the income that you get. So we have issues there in regard to research. Now there's a paradigm shift that is also happening. This isn't really a challenge, but it's something to keep in mind, where before global health research was more communicable diseases, right? It was AIDS and HIV and malaria, and although those are still prevalent, you can imagine what is actually happening around the world right now, and that's non-communicable diseases, right? Chronic conditions, cancer, heart disease, blood pressure. So now we're seeing this really interesting mix of comorbidities with those communicable diseases, and it affects us as researchers. So now I want to provide what I dubbed I couldn't think of a catchier title, but the epidemiology to policy framework of how do we go from research, from an epidemiology standpoint, to inform a cost-effectiveness analysis. And at the core of this is helping countries use their money wisely to inform policy, right? We want to make a difference on a country level to inform policy. And just to take these step by step, epidemiology, if you don't know the heart of the definition, this is by Ken Rothman. He's probably the grandfather of epidemiology. He describes it as the distribution and determinants of disease frequency. So what makes disease spread, its virulence, its numbers, and how many, the prevalence and incidence of the disease. Now I would like to add that epidemiology is a study that needs to matter to real people in real communities and in real life. You remember that policy link? That's the reality of it. So our studies are not done just in a silo for a high impact journal and to publish if it doesn't matter on the ground. Now, epidemiology can overcome this problem of attrition. Do you remember that Castigate, the loss to follow-up and attrition that happened? If you're asking people to come back to have blood pressure measurements monthly, and you have attrition, you have a missing data issue. What do you do with missing data? Traditionally, you've had to throw away that missing data and do a complete case analysis. So remember, you're left with that randomized clinical trial cohort of people that probably look different than your initial cohort. So the results are not generalizable. Now we have some really powerful epidemiological tools to overcome missing data. So you can do inverse probability weighting or multiple imputation, where you can now impute the missing data values and keep your robust data set. You can also address confounding through traditional techniques that we use in statistical models, but now we have marginal structural models that we can use to overcome confounding better than we ever have before. And then we have GIS. If you've ever worked with GIS, it is really good for policymakers and for countries to see the results of your work. It's a powerful tool to graph the geography of a place and then to interpose a statistical analysis to create buffer zones or hot spots with whatever disease that you're interested in. And then you can use mathematical modeling. Now this is going to become even more important for us in years to come, particularly with these chronic conditions that are now becoming more prevalent. You know, it takes 20, 30, 40 years for some of these diseases from exposure to the outcome to actually pop up. If you try to do a study over that time, if you run the risk of attrition and it's very costly. You can now simulate what will happen over decades of work with a little bit of a margin of error, but at least it's better than having to do a very long longitudinal study. So we've covered what epidemiology is, and now let's talk about cost-effectiveness research. And this can really help overcome the challenge of a country being financially constrained, right? They want to use their money wisely. That makes the biggest impact, and that is cost-effectiveness research. Now there are two things to note. This is a graph from the Tufts registry from 2000 through the present day, through 2012. And it's the number of registered cost-effectiveness research. Over time it's gone up, but look at the blue bar. That's in high-income countries. The red bar is in middle-income countries, and the green is in low. So the places where we need the cost-effectiveness research the most it's where it's been done the smallest, right? Which is really disheartening. And it's a need to do this type of research. Also, we need to evaluate strategies, not just technologies. And what I mean by that is you can have a great new diagnostic mechanism that works better than whatever the current standard of care is. However, do you need a community worker to conduct that, or a physician? Do you need a highly sophisticated and expensive PCR, or can you do it just as a rapid test? Do you need people to come back to get their results, or can you give it at the point of care? Do you see how that one technology, when you cost it out, it's going to cost more, depending on all of the implementation of it. So it's an implementation science issue, which is another buzzword we have in research right now. Now, I'm sure you're all aware of this paper. It's the Global Health 2035 paper in The Lancet. And it dealt with this issue of convergence, saying that the health that we see in low and middle income countries can actually converge with high income countries. Now, what was interesting that they found, which is just one of these quotes I pulled out, most of the incremental costs in low income countries for convergence to happen are health systems costs, which account for 70% of all costs in the first 10 years and 60% in the second 10 years. What that means to me is that when we are doing cost effectiveness research, we have to take into account those health systems costs that are needed to be strengthened or that are existing if we want to do a head-to-head comparison of any new technology, especially if our long-term goal is convergence. So we've done a really good epidemiological study. We've overcome the problem of attrition. That's informed cost effectiveness, which has informed countries that are limited. And then it can inform policy. So I think a better way to talk about the policy issue is just to show you an example of my own work. So I studied rapid HIV testing in Malawi among infants who were HIV exposed, born to HIV positive mothers, and followed them up throughout the breastfeeding period. Now, very briefly, why this is important right now is over time, and particularly since the global plan set out a very ambitious goal of reducing pediatric infections to 5%, which is really ambitious, they started bolstering up PMTCT, or the Prevention of Mother-to-Child Transmission Services. And so ART, the antiretroviral therapy, was disseminated to rural areas. Women were really encouraged to get into care, and it made a difference. We saw ART coverage among HIV positive pregnant women increase from 10 to 62%. We saw pediatric HIV infections drop by 43%. And over half of all pregnant HIV positive women receive some form of PMTCT services. So this is really exciting. This is what we want to happen. However, nearly all of these increases have occurred during the prenatal period or at delivery. But once the baby is born, what happens? So I see two limitations in the current recommendations. The first is in investment dollars. So this is UNAIDS data from 2011 to 2015. Now the take-home message is investment dollars have gone up, right? This is the bolstering of PMTCT services that have happened. But everything in this large brown bar and below are dollars given to the prenatal or delivery period. Anything above is the postpartum period. And then if you go to the even smaller brown box at the top, that's the investment dollars given to testing these HIV-exposed kids during the postpartum period. It's very, very minimal. The second limitation is the cascade, typically for the infant, stops after delivery or at best at the 6-week virological time point. So an HIV-positive mother gives birth. She's to bring her child back at 4 to 6 weeks to receive a PCR to make sure they're not infected through the delivery period or while the mother was pregnant. If that child is deemed HIV negative, you're supposed to come back at 9 months and then at 18 months for rapid testing, meaning that entire 18-month postpartum period, there's only 2 testing time points where this child is continually exposed to the virus. Now, prior to 2010, this wasn't too big of a deal because HIV positive mothers were expected to breastfeed for 6 months and then use formula. In reality, what happened, and if you were in the global setting during that time, formula was stockpiled. Crates of formula came in. So HIV positive mothers, most of them ceased breastfeeding and used formula. Now, in 2010, the guidelines changed due to some pretty significant findings that it's better to take the risk of transmission and go ahead and breastfeed because more of those infants were dying of diarrheal diseases. So they changed, and so now mothers are encouraged to exclusively breastfeed for 6 months and continue through the first year to 2 years of life. So the implication is now the risk period, where before 2010 was very minimal. Now it's long. Now you remember there's only those 2 testing time points, so keep that in mind. Now the implication of these limitations is we're now estimated to see a shift in pediatric HIV infections, where before the bolstering up, remember 70-80% of those infections occurred either while the mother was pregnant or at delivery. They brought that down, so now it's estimated that 50% of new infections occurred during the postpartum period. And in areas with extended breastfeeding, like in Malawi, a lot of women breastfeed through 2 years, 8 out of 10 new infections will occur during the breastfeeding period. Remember, 2 testing time points. I know I keep making that, but I think that's the highlight of why there's a definite need. So the risk period during the postpartum period is about 11 to 16 months with those 2 testing time points. Now to add a layer of complexity to it, if you give a rapid test to an adult, a positive is likely positive and a negative is likely negative. However, if you give it to a 9-month-old, a positive could be a positive, it could be an infection, or it could be maternal antibodies talking. So what happens in reality is if you have a child with a positive rapid test, probably below 12 months of age, if they're not sick, they're sent home. And they're advised if the child gets sick, bring them back in. At that point, if that was a missed infection and they're already sick, 80% will die by 2 years of age. So it's incredible because the disease progression occurs more rapidly in kids, so it's incredibly important to get these kids early. So to put it all together, if we're trying to tell this story, breastfeeding guidelines have changed that have extended that risk period, but testing has not. So what we aim to do is incorporate the extended risk period and try to define, is there a way to test these kids during this time that is, 1, cost effective, and that is 2, that is actually effective in catching those infections earlier or ruling them out instead of giving a false positive result to the mother. Ultimately, the policy outcome is to redefine the Castigate to include that breastfeeding infant. So our study was part of a neurodevelopment study conducted in Malawi in 2 health centers that both provided PMT-CT most of the time at delivery or during the prenatal period. We had a sample size of 121 infants, and they were all HIV negative at 6 weeks of age. So they came in for their 6-week time point. They were HIV negative, so any infection that occurred afterward was through the breastfeeding associated. We asked them to come back every 3 months of age through 18 months, so at 3 months, 6 months, 9, 12, 15, and 18. And we gave them 2 point-of-care rapid tests. These Determinant and Unigold, they are point-of-care HIV tests. You can do them in 15 to 20 minutes. It eliminates the need, if you do a PCR on an infant, that mother has to come back. But attrition is about 80% by 6 months in the breastfeeding period. So we want to do a point-of-care test. So we did that at every 3-month cycle, and we also did a PCR for a gold standard to compare our results. Now, as you can imagine, we weren't in a perfect world, so we had quite a bit of missing data, where mothers didn't come back at every 3-month interval. We also had stockouts of Unigold. It's in the real-world setting, so we ran out of tests a couple of times. So we imputed those missing values using multiple imputation. Now, we also collected data on 3-month intervals. So if we had an infection at 6 months, did it occur at 3 months, at 6 months, or somewhere in between? You can create a Kaplan-Meier survival curve using interval censoring to account for that. And then we used modeling, which I'll definitely go into detail. So specific aim 1 was just to evaluate the performance of the 2 tests. This is traditional epi. You can do it on the back of a napkin. Sensitivity, specificity, positive and negative predicted values. Aim 2 was to determine the median time to seroreversion. That's the time that the maternal antibodies decay enough to where if a child gets a positive, it's really likely it's a true positive instead of those maternal antibodies talking. And then 3 is to put it all together and try to identify an algorithm that worked best. So here's aim 1, just how well did the 2 tests do in regard to excluding HIV infection. On the x-axis is the age of the child, so it shows the trajectory from 3 months to 18 months of age. And as you can see, the specificity of the test was really low at the beginning, which makes sense since most positives you're gonna have a lot of false positives. Maternal antibodies haven't waned very much then. Now look at Unigold, which is the dotted line. There's a sharp increase where it reaches over 95% by 9 months. But Determined doesn't reach 90% until you get to 15 months. That's because determine will continually give more false positives than a unigold. And it has a dramatic implication of what test do you use. If you want to catch all positives, do a determine. But you have to follow up those positives with a PCR. It's expensive. On the converse, if you want to rule out infection and give mothers more of a, a reliable test that no, your baby isn't negative, continue to take your ART, you do a unigold. So it matters. Now, how well did the test actually diagnose HIV? Overall, both of them did pretty good. We have 100% in a lot of places. However, in the middle months, of 9 to 15 months, we saw this U-shaped curve. And that's driven by false negatives. So who these kids are is they are true infections, but when they tested on a rapid test, we got a negative test. We missed those infections, which have a 40% higher mortality rate than if we would have caught them. Detrimental to the infant. So second, the decay of antibodies, or when the maternal antibodies wane. Not surprisingly, we see something different. Where in unigold, which is the red, they waned earlier than determined. Remember, because of this false positive issue, so that means it's going to continue catching those maternal antibodies for a longer time. And then the third, which is really the meat of this study, is this cost effectiveness research. Now, we evaluated a lot of strategies. We first started with what is the current standard of care. This is what I've been harping on, 2 testing time points at 9 and 18 months that the WHO recommended. It's what's currently done. We did a head-to-head comparison of 3 point-of-care tests. The DT is determined, the UN is unigold, that's what we studied. And then we also added this point-of-care Alere test. It is a brand new test that has been studied within the past year and a half, so we didn't have it at our disposal. It's a point-of-care PCR. It's a phenomenal test, highly sensitive, highly specific. It doesn't produce nearly any false positive or false negatives, but it's $25 each. The other test is $5 to $6. So if you're doing these on 10,000 infants in your cohort per year, it matters what test you use. So a head-to-head comparison of those. Then we also asked if countries can only afford one testing time point per infant, which is the better time to do that? So we looked at 6 months, 9 months, 12 months, and 15 months. Again, head-to-head comparison between the 3 rapid tests. And then we asked, is there a better time if you use 2 testing time points than the recommended 9 and 18 months? So we tested 6 and 12 months and 6 and 15 months, again, with the 3 different rapid tests. So in total, we had 21 strategies that we were trying to compare. Now to do this, we used a Markov model, which is a really efficient, iterative type of mathematical modeling to use. Before, if you do a decision tree, we're following these kids from 3 months of age to 18 months. At any point in time, they can occupy what we call health states, which is what you see in the bubbles. So just imagine with me, everyone at 3 months of age starts out as a true negative. These kids are not infected. They come back again at 6 months of age, and what do they become? They can remain a true negative. They can become a true positive or become infected and the rapid test caught it. They can become a false positive, meaning that's maternal antibodies talking, or a false negative, the rapid test didn't catch it. At each 3-month cycle, kids can transition between any one of these bubbles, which those probabilities of transitioning is comprised in the transition matrix. So you calculate the probability of the kids going between health states based on the sensitivity and specificity of the test. Now, as you can imagine, these matrices change depending on where we are in the time point. That the probability of being a false positive at 6 months is much higher than at 15 months. So we had to build these matrices per time point and per 3-month cycle. And that's what you see here. So we built it for determining unigold based on our data, the traditional epidemiology findings that we have of how they transition. And then the Alere, there are only 2 tests that have looked at it in Mozambique and South Africa with sensitivity and specificity parameters, and they agreed with one another very well. And it was highly sensitive and highly specific in both cases. So we used that to calculate our probabilities. Now, for every model, you have to have a set of assumptions and a set of parameters. Because we used our data, we assumed that our beginning cohort of people, of children that we were assimilated, looked similar to the ones that we had in Malawi. So those are our top baseline cohort assumptions. 51% were male. The median age of the mother was 27 years. And exclusive breastfeeding and mixed feeding was generally high in the beginning, and it waned a little bit. But if you notice the mixed feeding right here, by 12 months, 40% are still doing some sort of breastfeeding. In 18 months, almost 20% are still breastfeeding. So we have that good extended risk period time. We also based our transmission risk on what is seen right now in the literature. We varied, is the mom on ART? Is she mixed feeding? Is she exclusive feeding? It's different depending on all of those factors.
Can I just ask a question?
Yeah.
Are they percentages for exclusive breastfeeding for the 54?
Yes.
So if 54 are exclusive breastfeeding, how can 87 be doing mixed? What's the MT? Mixed.
Oh, that's mixed. So that includes exclusive breastfeeding or the additional.
Okay.
Who's
So
doing
the
mixed.
difference would be those who are doing mixed.
Only mixed,
Yeah.
right.
Okay, thanks.
Yeah, I should.
Thank you.
for pointing that out. I should put it in.
It's just the
there.
statistician in me.
Yeah,
didn't add
no,
up
that's
200.
good. That's good.
Yeah, thanks.
Good clarification.
Thanks.
We also need input parameters, and we already discussed that for sensitivity and specificity and the probability of transferring between one health state to the next. And then, and this table is very long. These are just selected parameters that had the biggest impact on the model. So I'd be happy to share the rest of them. But another significant factor is cost associated with each test result. So the cost of a false positive result was the cost of the rapid test and the cost of the PCR, because all positive tests, regardless if it's true or not, were followed up with a PCR, and then pre and post test counseling for those. Now, a true positive result was much larger because it included treating that infant with ART. Now, when you look at the ranges, 584 to 615, this lower number is determined in Unigol because it's cheaper than a PCR, which is always the highest range at 615, so keep that in mind. And then the cost with a false negative or a true negative was simply the cost of that rapid test and pre and post test counseling. So you put all these assumptions and parameters into the Markov model, and we simulated what would happen in a cohort of 10,000 kids based on this data from 3 months to 18 months of age, and then we followed them throughout their lifetime horizon. So you can imagine a false negative kid had a higher mortality over a lifetime than those that were caught early and that were put on treatment. So keep that in mind. So some selected results just based on the base case analyses. What was the cost of each strategy? How well did the strategy actually perform in catching or ruling out infection? And then the cost effectiveness is putting it all together. And then we conducted sensitivity analyses to run all of our findings to evaluate how robust it was. So here's our 21 strategies on the left-hand side. They are ranked in this column from lowest costing strategy to highest costing strategy. Remember, these are 10,000 kids. So, for example, the lowest costing strategy was a 9-month Unigol. Among 10,000 kids, it cost $182,000 to test all those kids throughout that 18-month period. Now, the 3 lowest costing strategies was Unigol, either conducted at 9 months, 12 months, or 6 months. This was because it didn't produce as much false positives, so you didn't have to do unnecessary PCR follow-up. The next were determined at 9 months, 12 months, and 15 months. And it's not surprising that the ALIR, or the testing strategy, the testing algorithms that had 2 testing time points became the more expensive. So the most expensive was doing an ALIR at 6 and 15 months, and it was about $1.5 million for 10,000 kids. Now, if you think that there's 1.5 million HIV positive women giving birth per year, and we were supposed to follow up their infants for 18 months, we only followed 10,000 of them. So keep that in mind when you're looking at these costs, especially for countries and policy. Now, our clinical outcomes were measured in terms of a DALY. It's a disability-adjusted life year. And what that is it is a combination of the years lost to death from disease or disability from disease. So if we have a child with a false negative, and they die at 2.5 years, but given they weren't HIV positive and they would have been caught early if they would have lived to 63 years. their years of life lost is very wide versus if we caught that child early and they ended up living longer. So it's a combination of the two. And a rule of thumb is the higher the DALY, the worse the outcome when you're making sense of these numbers. So we're just building on that table that I showed a minute ago. The left-hand side are the 21 strategies ranked in order of lowest to highest cost. This third column tells you the ranking of the cost, just for reference. And then here are the DALYs. Remember to keep in mind, the higher the number, the worse they actually performed. So look at the lowest costing strategy, a 9-month Unigold. It was very low cost, least expensive. It had the worst outcome. It had the highest DALY out of all 21. Conversely, the lowest DALY, or the algorithm that performs the best in terms of lowest DALY, is a 15-month Alere. Next in line is a 6 and 15-month Unigold, and then a 6 and 15-month Alere. So the top 3 strategies that had the lowest DALYs and performed the best were some of the most expensive. So how do you make sense of that? How do you combine the two to actually inform a country to spend their money? And that's through what we call the incremental cost effectiveness ratio, or the ICER. And what this does is it gives you a ratio of how much a strategy cost it will compare to the effectiveness of those strategies. So your numerator is the incremental resources required by an intervention divided by the difference in the effectiveness of those two will give you an ICER. Let me show you how this played out in our data. There we go. So if we want to compare, you always compare in sequential order from lowest to highest cost. We compare a 12-month Unigold with a 9-month Unigold. Again, there's the cost and the DALYs associated. This incremental cost means that it would cost an additional $51,000 to do a 12-month Unigold as opposed to a 9-month Unigold. Because of that, you would avert 33,000 DALYs, which means that it worked better, but you're going to pay more for it. So it gives you an ICER of $1.53 per DALY averted. Now another example is you sequentially continue to compare the strategies. You compare a 6-month Unigold with a 12-month Unigold. It's going to cost you $72,000 extra to do that, but we have a gain in DALYs of $6,800, meaning you pay more and there's worse outcomes. We call those strategies dominated and they're eliminated. It doesn't make sense to do those if you have poor outcomes. So you continue to do that all the way down until you finally identify the cost-effective strategies. And 4 popped out. One was doing a 12-month Unigold, one was a 12-month determine, a 15-month determine, and a 15-month Alere. Now a better way to see that is what we call an efficiency frontier, where you plot all strategies and the cost-effective strategies are connected with this dotted line. So remember, 9-month Unigold was the lowest costing strategy. If you want to avert DALYs, which we're moving this way now, it'll cost you more. With 12-month Unigold, avert more, it'll cost you more, 12-month determine, and on and on. So at the end, the lowest DALY was that 15-month Alere, but there's that cost differential between the two, and all other strategies were dominated. So those are our base case results, where we just use 1 point estimate to calculate the transition probabilities. Now, you can imagine there's uncertainty in all of our parameters, and so you can conduct sensitivity analyses, both deterministic and probabilistic analysis. So first, for deterministic sensitivity analysis, what happens, we set our costs just on what is currently used, but what happens if we go to a country where cost of treatment is much higher? Or what happens if we go to a country where the cost of Alere is much cheaper? It creates that confidence interval. So we conducted the robustness of the model techniques to see if that affected the actual ICERs. And then mortality, what if all women get put on treatment? Because now we have option B plus enrolling in countries where now all HIV positive women aren't put immediately on ART and continue through life. That'll decrease mortality because you're decreasing infection. So that created a confidence interval. On the other hand, what if we went to a country that no one's on ART? We have really large problems in resource allocation. That's going to affect mortality. Those were our parameters. And then our test performance was one of the largest one that I was really interested in. If you remember, the sensitivity for determining Unigold at most times was 100%. that confidence interval was 50 to 100. It's really wide, but the confidence interval of an allele was 95 to 100. It's very small. So did that affect either our cost or the overall dominated strategies? Now I have about 30 pages of all of these results. I did not bring them, but I would love to share them. But the take-home message is uncertainty in any of those, and cost, mortality, test performance did not affect the strategy, cost, the effectiveness, or the overall ICERs that were dominated or undominated. Next, you can do what's called a probabilistic sensitivity analysis, where you put all the uncertainty together. And you say, given all the uncertainty and all the parameters, how robust is my findings in the base case model? And you do that by what's called an ICER plane. So these are our four dominant strategies that we found that were cost effective. And what you do is a Monte Carlo simulation of 1,000 trials. And every single trial, it'll produce a new ICER point estimate, given all that uncertainty. So you're going to have the first ICER, for example, for this top left one was $1.53. You're going to have some ICERs that were negative $5 and some ICERs that were positive $10. You do that 1,000 times and you plot it on this ICER plane. Now what you want is you want those 1,000 draws, 1,000 point estimates to be in this upper right-hand quadrant, meaning that it's still cost effective. Anything outside of that was either dominated or not as cost effective. So overall, we're pretty pleased with these results that 6 to 10% of the time the strategies became dominated. 90%, 94 to 90% of the time, they remained dominant. So we feel like it's a very robust model at the end of the day. So to put it all together, back to our framework, we did our traditional epi back of the napkin calculations. We used that to inform cost effectiveness analysis that simulated 10,000 children over that lifetime horizon. And now we can actually inform policy, that we can tell countries, depending on how much money they have, use this test or use not. The current recommendations say use a rapid test. They don't provide which one to use. And as you can see, it matters which one we use in terms of cost and how well we actually test those kids. So at the end of the day, I don't think I have my favorite strategy. I think, again, it depends on the context and the country. It depends on if you want to catch all positives and you're okay with PCR testing, or if you want to give mothers more of the benefit that no, your child is still negative, which might motivate her to continue on her art. So in conclusion, given all of this and given who I want to be as far as an epidemiologist, I think success for me looks like three different things. One is to be involved in interdisciplinary research. Early on in my career, I met Paul Farmer, and I asked him, what does an epidemiologist do in global health research? And he said, be interdisciplinary, and he walked away. and I remembered that. I mean, I was naive enough to just write it down, and that was my goal, to bring my training as an epidemiologist and the rigor of these new methods to the table, but also be involved in a team that's part of a vision bigger than myself, where you all come together. And I definitely think that's part of the uniqueness of DGHI and DGNN. And then to tie all research to health policy. If it doesn't matter to real people, to on the ground, then it might not be worth doing. And then to train the next generation to really, I've been very fortunate to receive mentoring myself, and I would like to do that to root tenacity. Typically we see in students, also with scholarship and with rigor. I'd like to acknowledge my committee at UNC. My chair was Dr. Annalise Van Ree. The committee members were Jeff Stringer, Bill Miller, Stephanie Wheeler, and Michael Hudgens, and also the women and the children who participated in those studies and my funding mechanisms. Thank you for having me. I'll be happy to hopefully answer questions.
I have a question. So my question is about social cultural context, and so are there differences in how the tests are administered? Are they all?
No.
So
They're pretty much heel stick, put on the paper itself.
Any assessment of social cultural practices across different sites that might either enhance or restrict the likelihood of mothers participating or following the regimen?
Not that I'm aware of. These strategies were also we tried to build them around existing vaccination schedules. So they're already bringing their children in, they're getting shots, they're getting hill sticks. And so I'm not aware of there really being a cultural bar to that. Thank you.
I have a related question, and it's actually thinking about kind of the biomedical care setting as a cultural setting, I guess. You had mentioned that often that there's a positive result.
Yeah.
They just kind of assume that it's the mother's antibodies and send them home.
Yeah.
Is there a way to kind of model based on maybe some, I mean, I guess this is assuming that the people would be retrained so that they're actually doing the PCR consistently, but is there a way to model whether that's just going to continue kind of not happening? There's not going to be a shift in the kind of culture of the way the testing is happening?
Oh, to get healthcare workers to do a PCR? I'm not sure if that's a cultural thing as opposed to a financial issue. Because those PCRs are $35 each. And you have to have that sophisticated tool, and in some places, especially in Malawi, those aren't in every healthcare system. So it might be retraining and getting healthcare workers to actually do a PCR, but I think there's some logistical constraints to it too. Does that help? Yeah.
So thanks, Henry. Very interesting presentations. I could not agree you more about the importance of doing cost benefit cost effect analysis of strategies instead of technologies.
Yeah.
But what you are talking here, I found is still look at the cost effect analysis of narrowly technical strategies. If you really want to look at the cost effectiveness of strategy, including the organizational strategies, you need to talk about the cost of lobbying, cost of advocacy, and the cost of capacity buildings in some trainings required for the health workers on the ground in order to undertake these kinds of new technologies in competent ways. So I think still there's something missing in terms of overall, grand strategies that we should use.
I agree with you because it's informing the mothers. Please come back. Please come to every test. Stay on your art. Right? I mean, it's very different. Unfortunately, we didn't measure any of those variables to actually account with a good level of certainty, but I agree with you. Thank you.
I have three interrelated questions, so take just any one of them. So I'm curious about your choice of DALI, because both DALIs and QALYs have got methodological problems, so I'm curious about that.
Yeah.
I'm curious about your confidence interval being so wide and how that has just these confounding problems throughout, even with the Monte Carlo analysis. I'm just curious about that. And then this Markov analysis, it looks like this is not a static, but a dynamic model. And I'm curious, did that dynamic model include avoided costs? So someone tests negative, therefore there are additional costs in future administrations of the test, the diagnostics that were avoided, and how you handled that. Because then there your assumptions really matter, because the costs that are avoided can be really considerable.
Yeah. No, those are great questions. We did not look at the avoidance of cost. It was just the cost of the strategy. We tried to take care of the issue of what did you avoid by not having to do additional costing with the DALI and over the lifetime horizon, with some of those in the background noise of the model, especially over the lifetime horizon. We made assumptions at each 5-year interval as well in regards to testing and how many adults got infected throughout the trajectory. So we tried to capture it that way. The uncertainty in the parameters, I could not agree with you. We had 121 children, or I could not agree more with you, I guess is how I should say that. Yeah, thank you. We had 121 kids and 21 of them became infected. So our sample size to evaluate those parameters were very low. And it would be worth it now to do a head-to-head comparison of rapid tests in a large cohort of infants. Determinant and Unigold are not the only two rapid tests used. So maybe to really make a robust study that'll hopefully reduce those confidence intervals. But we do feel pretty secure in the robustness of our model, given the uncertainty, the probabilistic and deterministic parameters. And we evaluated, especially in the deterministic, did it affect cost and the ranking of the cost, which would have affected the ICERs, the effectiveness, the DALYs, and minimum and maximum. It was pretty substantial on how we looked at it, and overall it didn't affect the dominated strategies. But it would be very nice to do a larger study.
Thank you.
Yeah. Hi.
Thanks for a great talk, Emily. One of the things that policymakers kind of find hard to absorb is kind of complex, difficult papers or difficult studies. We know that they want kind of punchy, easy messages. They want to hear music instead of noise, short attention span. So just to put you on the spot and to be a bit mean, if you were with a policymaker now, and they were like, look, I've got a minute. What should I do with this? And particularly that efficiency frontier, which I think essentially kind of shows a trade-off, right? You'll have to pay more to get a test. If you had if you were in the elevator, as they always say, with the policymaker, how would you, what's the trade-off here, and how might they use this in their sort of practice?
When I started doing this, I thought I would have a punchline. And then we get to the results and you realize you don't. I think I would ask them, what's their GDP? What are they willing to spend? And then draw the line right there and just tell them, you won't avert this many DALYs, but here is where you lie. If you will invest more, then you can avert a couple more thousands or however many DALYs. But I would ask their GDP and how much they're willing to spend.
Well, I have a related question to that. Doesn't it matter how much per capita I'm investing? I mean, the very notion of if I'm less than $30 per person per year, I'm not sure I'm interested at all in this. It's wonderful work, but I need roads, I need steady power supply, I need healthcare workers.
Right.
So the follow-up question to me is when you say it depends. Can you say more about that? It depends on what? In other words, do you metric it to how much the annual investment is in terms of healthcare overall? Or, I mean, just in practical terms, when you're in the elevator with a policymaker, how do you nuance that? I'm really curious.
Well, I think it's also important to know what the Ministry of Health wants to do. In Malawi, they have a very strong initiative to reduce mother-to-child transmission. So there you have a captive audience of how much are you willing to spend. On the other hand, I would probably ask them, what are your goals for the country? And then you can get a sense whether or not they're actually going to spend money. On the converse, you could also say, maybe we should focus all of our money and effort in getting those mothers on ART. Then maybe instead of doing testing, we should just really focus on education, and you could even do observed therapy on those women. And if you do that, you reduce the transmission risk to 2%, like we see here in the country. You don't need to test those babies. So I just think it depends on the priority. And I don't like saying that, it depends again, but maybe to know your audience of what their priorities are.
I have a question more on the specific context of Malawi and kind of like a willingness to pay model. So I'm assuming the government is paying for this, but like from your research, what was the level of understanding among the women of how important this test was? And has anyone done a willingness to pay model to see like what are they willing to pay for transport? Do they need to go to a hotel? Because there's only 2 clinics and I don't know if that was just for this. Or, so is there any knowledge of what the women or their families are willing to pay, not just the government?
Not that I'm aware of in Malawi, these willingness to pay. I think that's really important. I just don't think the country is focused on that specifically. Now, in terms of the global health plan of reducing that transmission rate to 5%, Malawi is inching towards the top of the country, so that they're doing a good job. So it wouldn't surprise me if now, in the future, they're going to be doing those type of analyses. But really the focus has been the prenatal and delivery period, and we're now seeing a shift to the postpartum period.
Thank you.
Thank you.